Hi everyone, my name is Maniraj. Thank you for your time and interest in listening to this lecture on language justice in healthcare. Sparked by language inequities I noticed in clinical practice and my experiences as an immigrant in this country, I started exploring the field of language justice, and my hope is to share what I've learned through my research, and I thank the course instructors for holding this space. I have two disclaimers. Part of my education on language justice was made possible through a research grant with the American Academy of Family Physicians Foundation, and I'm very grateful for them. Secondly, I'm not a content expert. However, I invite dialogue, teach back, and sharing of any resources that I can learn from. And you see my email right there. Please reach out. With that said, here's what I hope to cover during this talk. I want to first start off with trying to define language justice. I found a hard time finding a concise and consistently referenced definition of it. And so I took the available definitions I found online and created a word cloud that is set in the background here. And the most common words that are used are the ones that are in larger font. And those are communicate, access, services, individuals. And then using the definitions that I could gather, and then my own kind of conceptualization of it, I came up with the definition listed here, which is the ability to communicate health needs and understand health and healthcare unaffected by language skills. By language skills, this runs the gambit of language itself, dialect, fluency in language, etc. You may have heard the term of LEP, or limited English proficiency, before to refer to individuals who do not speak English as their primary language. There is an argument, partly semantic, to remove this terminology as it is stigmatizing. It portrays those who do not speak English as their primary language as deficient, which is unnecessary. An emerging term that is preferred is non-English language preference, which removes the stigmatizing term of limited and instead communicates a preference to speak in one's preferred language. Why should you care about language justice? First, there's a moral and legal aspect to this. The first three bullet points mention laws related to language justice. Section 1557 in particular calls for meaningful language access to non-English language preference individuals and mandates the use of qualified interpreters. The latter three bullet points are policies and guidelines on how to provide meaningful language access. One that might be of particular interest to you is ACEPS, which is the American College of Emergency Physicians, who advocate for the use of, quote, the qualified interpreters in a modality that best fits the clinical situation, end quote. Through my research, which includes doing focus groups with patients with a non-English language preference, patients have shared frustrations with the use of phone and video interpreters in emergencies, and I'll share a specific patient quote a bit later. I was asked to include case studies on medical interpretation and language access issues. Thankfully, partly by the nature of working in mostly primary care, I do not personally have an egregious experience or horror story I've witnessed where medical interpretation led to poor patient outcomes. The one experience I have to share is where a Spanish-speaking patient of mine was not provided interpreter services through a pharmacy, and as a consequence was not able to pick up his diabetes medications, resulting in worsening A1C at the next visit. This is just a small example of what I experienced in primary care. However, there are well-documented instances in the literature, blogs, legal proceedings of inadequate medical interpretation services severely harming patients. There is a case of a hospital using unqualified interpreters, and in this one instance was a minor and child of this patient to translate that their patient was encephalopathic, and she used a word that translated to intoxicated or drug overdose when she was not trying to do that at all, and instead was trying to mostly communicate encephalopathic, and so that was misdiagnosed as overdose when it was actually a brain bleed. There's also other instances of the lack of qualified interpreters leading to a medication getting a medication that he was allergic to, and the list goes on. To provide some statistics on language access in the emergency room, studies cite anywhere between 12 to 32% usage rate of medical interpreters. It appears that use of medical interpreters drops as a patient progresses from triage to ED disposition. With some of that background information, I wanted to prioritize talking about what can be done to move the needle forward in terms of language justice in the emergency room. In the next few slides, I'll walk you from registration to ED disposition, fully aware that you may not have any control over quality improvement initiatives at registration right now. You may find yourself in leadership positions in the future where you can impact language access at multiple touchpoints. Important ways to improve language justice at registration and rooming include providing language concordant care at check-in, so the use of bilingual staff or in-person interpreters is preferred. The second is having written documents available in a patient's preferred language. Through focus groups, I have heard from patients being asked to sign documents they had not had a full chance to comprehend. And these medical legal documents are often translated real time via interpreter to staff, by the staff to the patient. And they don't get a chance to actually read the legal language itself. And patients expressed a lot of frustration with that. There was also a separate instance where a patient I was speaking with said that he was going through a check-in kiosk at a clinic, and it was only in English and Spanish. He did not speak either of those languages or understand either of those languages fluently. And as he was going through, it was asking him to pay as account balance, which was a very large bill that he did not need to at this time. And he said if he did not catch that, he might have needed to pay a bill that he did not need to at that time and would have been detrimental for him. And so having written documentation and written accessible features and translated documents are super important for patients. And the third is adoption of universal signage to direct patients. And this includes like signages for bathroom, etc. Next, moving on to the clinical encounter itself. 3 ways you can make a direct impact include prioritizing in-person interpretation by a qualified interpreter. I stress the in-person component here after speaking with a patient about his experience. He was taken to the emergency room because he was bleeding and in excruciating pain. The staff put a phone interpreter near his ear, and the interpreter had a hard time hearing him in a loud environment. And because the interpreter was not there, he had no context to the patient's severity of pain and did an ineffective job communicating this. The patient remarked that the interpreter, and by extension the staff, came off as indifferent or cold towards his pain and how he was feeling in general. In contrast, he shared how when an in-person interpreter was available, he was literally in so much pain that he crushed his interpreter's fingers. And this really helped communicate the intensity of his pain to the care team, and that was helpful to his overall care plan. Many languages, as you know, have significant differences in the dialects, and it's important to not only inquire about the language you speak, but also if there's a certain dialect that they communicate in. And one of my focus group participants shared a very frustrating invalid experience when an interpreter asked them why they don't speak, quote, the formal version of the language. And understanding that it's important to find interpreters who kind of are non-judgmental in that way, which you don't have much control over. But on your end, you can do your due diligence by making sure that you get a patient interpreter, that speaks speaks in dialect concordance. And I just recently found out how to do this through one of our tablet software interpretation services. You can literally just go to the operator and specify there, and I encourage you to do that. Lastly, this is more of a cultural nuance, but it's very much intimately tied to language interpretation services. But some individuals may have a cultural preference to what kind of interpreter services they like, specifically gender preferences. And so some of our participants said that they do not want to talk about gynecological complaints using a male interpreter. And one participant said something to the effect that if they don't have a gender concordant interpreter, they would rather choose not to talk about their gynecological complaints at all, which can be very detrimental depending on the situation. Wrapping up here. So I know the emergency room gets really busy. but patients who do not speak or read English have a much harder time understanding, interpreting, and following up on their results. It goes a long way to spend the extra minute or two to make sure they understand their care plan. While in clinic, I often spend some of my time calling a specialist office while the patient's there with the interpreter on the line to help make that follow-up appointment. And I encourage you to spend some extra time to make sure that they are truly understanding their care plan while they're with you in the emergency room. There is limited literature out there, kind of switching topics here to language justice and global health, but there's very limited literature out there on language justice in the global health space. But from my global health experience, here are a few things to think about. If you're not from that region of the world, think about your positionality as a non-native and what that does to the power dynamics. Speak to community partners about cultural missteps beforehand, and making sure that you understand things you should or should not be doing in that community that may or may not offend people. And be very mindful of your nonverbal cues during communication. Lastly, I'd like to end with a couple of slides on how to be a language justice advocate. So first, I encourage you to learn about your department, institutions, or state policy on language access. For example, the North Carolina legislature, as of 2024, does not provide reimbursement for non-American sign language interpreter services, and this limits the ability of practices to financially reimburse for interpretation translation services, which just limits access to care. Second, speak with your patients, caregivers, staff, interpreter services on language access growth areas. So I had the chance to meet with our institution's interpreter services department, and in fact, our staff there will be giving a presentation which will be shared with you on working on how to best work with them. Third is to advocate for more language accessible features in the ED and really try to push for more in-person interpreters. And then fourth would be to consider meeting with state officials to discuss language access policy. So I've been speaking with my state representative and would be happy to share any guidance with you if you choose to do that, and kind of how my conversations have been going. Again, here's my email if you want to reach out about that. And thank you so much for your interest and attention. Please reach out if you have any questions. Thank you.